Ray here, and I would like to go over these uworld questions with you for internal and external development of the genitalia. And so the first question in the uworld bank that I saw that matched this material, a 5-month-old boy brought into the office a right-sided scrotal enlargement. The enlargement has been present since birth and increases when he cries or strains to pass a bowel movement. So that's the first part of really interesting information. So you know the scrotum is enlarged, but the enlargement isn't just constant, but when he has a Valsalva maneuver, increases abdominal pressure, then the contents from the abdomen or fluid or something is pushing into the scrotum, making it larger. There's no history of trauma or infection. The parents do not believe he's in pain, and they have not noted any discoloration. So they have an ultrasound, and the enlargement is a fluid collection of the right testes, around it, rather, not of it. So it says the specific defect giving rise to this patient's condition can also lead directly to which of the following. So you might remember that the testis descends, and with it, it takes a part of the peritoneum called the processus vaginalis, and I think they have a picture here. So you can see that the processus vaginalis, that usually is going to obliterate, this is the obliterated portion of it, well, sometimes it can persist. And so you can have fluid that will come down into this persistent processus vaginalis, and it can lead to, which is in this patient situation, there's just fluid there, but it could also lead to other abdominal contents like fat or intestines coming down through that route, which would be the normal route that the testes took, and so that would be an indirect inguinal hernia. And so that's the correct answer that they give you, all of these choices, and they give you the direct hernia, which is where the contents actually come through a weak part of the abdominal wall, directly comes through the abdominal wall, usually in the Hasselbalch's triangle. But in this case, this patient would be at risk for an indirect inguinal hernia. And then uworld gives you some information about it, some background information similar to what I talked about. And then it also tells you why the other choices are not correct, which I included these slides in the PowerPoint. Okay, the next question. In normal female development, non-fusion of the urethral folds form the labia minora and the vestibule of the vagina. In males, non-fusion of the urethral folds would most likely result in which of the following? So this is kind of similar to one of the questions we did in class, which I had added last year. And so when you look at these conditions, understanding what they are, at first these are all different conditions. If the scrotum is unfused, then you're thinking about the labioscrotal folds not fusing, so that one wouldn't be the correct answer. The other one that is related would be the epispadias, where you have an opening on the urethral opening on the dorsal side of the penis, and then the hypospadias, where you have an urethral opening on the ventral side. And so hydrocele and the cryptorchidism, they don't really have to do with the development necessarily of the just general structures of the external genitalia like the other choices have. So epispadias is going to be on the dorsal side of the penis, and you could have a urethral opening at any place here, and you can see hypospadias in this picture would be on the ventral side. So it's asking you essentially the urethral folds, which are in the midline, which one would this result in if you had abnormal fusion? Well, the ventral aspect of the penis is the part that actually is formed by the urethral folds. In contrast, the dorsal side is formed by the genital tubercle. And so that's why hypospadias would be the correct answer here. And so then they give you a little more kind of reading information, like little text, And they also talk to you, again, why the other answers are not correct. Next question. A 1-month-old boy is brought to the emergency department due to acute onset fussiness. So all of a sudden, this little patient is upset. The child was born at term without any complications, and the temperature is normal. And the examination shows a right-sided inguinal hernia that's not reducible. So we have a hernia, and it's not sliding in and out, but it's rather constant. The penis appears normal. The testes are not palpable, so in the scrotum there are no testes. Imaging reveals a mass adjacent to the herniated bowel in the right inguinal canal. So we have a herniation on the right side in the inguinal canal, and there's a mass there. So during the surgical exploitation, the mass is consistent with a testicle. So we have a testicle, we have typical penis development and scrotal development, because they didn't talk about there being any ambiguous genitalia. However, the testis did not descend on this right side into the scrotum. And let's see, and this is the right side, and it also says that the left testicle is identified intra-abdominally. So the right testicle is attached to this hernia in the intestines that has alongside the testicle, but on the left side, the testicle is in the abdomen. So neither testicle made it to the scrotum. However, the gonads appear to be associated with the fallopian tubes and a uterus. So here we have what we can only assume at this point is an XY patient that has undescended testes and typical looking external genitalia, because we haven't mentioned any ambiguous genitalia, but there are additional fallopian tubes and uterus. So this patient's findings are most likely due to a lack of the following hormones. So undescended testis isn't necessarily uncommon. And so that's kind of nonspecific. It doesn't tell you that there would be any lack of hormones. The external genitalia is a typical presentation, what we would have expected it if all of the pathways were followed. And so the only thing here really that is not expected would be the fallopian tubes and uterus. So as you look through the hormones, we see several of them that are important in developing these pathways for internal and external genitalia, but only one of them, the anti-Müllerian hormone, very specifically has to do with the regression of the paramesonephric duct that create the fallopian tubes and uterus. And so A would be the correct answer. And in this little schematic, they kind of show you the pathways, and they don't use the term paramesonephric duct. A lot of the upgraded terms are paramesonephric. We don't normally use people's names anymore to talk about the ducts. However, in this schematic, they did use Wolffian for talking about the mesonephric duct, and they use Müllerian to talk about the paramesonephric duct. And that also is used in the anti-Müllerian substance, so that kind of goes together, where it's just not always used. So you have to be prepared that they may not use that term. But that would be just for the duct. If you notice, the anti-Müllerian hormone and Müllerian inhibiting substance are still used for the hormones. So it's unfortunately confusing. I did not have anything to do with naming these hormones or ducts. Okay, and so then they give you a little description, very similar to what we just discussed, to recap the basic information. And then they tell you why the other answers are not correct. And then we wrote some additional formative feedback questions for you. Hopefully by the end of this learning module, you will feel really comfortable with the pathways that lead you to have typical development of internal gonads and external genitalia. And so you'll be ready to talk about variations in the next session. Okay?